Good morning, good afternoon, or good evening, depending on where you are joining us from. My name is Mary Napolitano, and I'm one of the product managers for Adaptivo. I would like to go over a few housekeeping items before we get started. As you may have heard, this webinar is being recorded, and you'll be sent a link after the recording just in case you get pulled away for clinical duties or have connectivity issues. All attendees are automatically muted. If you have questions, please enter them at any time in the GoToMeeting dialog box. They will be addressed at the end of the presentation. Standard Imaging, a leading manufacturer of radiation calibration and quality assurance instruments, is pleased to sponsor this webinar. I would like to introduce our speaker, Brian Pomije. He is a retired U.S. Naval officer with 24 years of honorable military service. Brian is an A.B.R board certified in radiation therapy physics. He has been working in the medical physics profession since 1991 and with 21st Century Oncology, now Genesis Care, since 2007. He has been doing in vivo gamma dosimetry, exit beam portal images since 2009, and he has been using Adaptivo for approximately 5 years. Now I would like to turn over the mic to Brian to give him the opportunity to share his wealth of knowledge with you. Brian, it's all yours.
Well, thank you very much, and thanks Standard Imaging for inviting me. Hello, everyone. I'm going to go ahead and give this presentation, but I'd like to start out with my first slide, which is more of an introduction. For those of you who do not use Adaptivo or are not familiar with it, there are two different calculation modes that can be used for the gamma calculations. There's a predicted mode, which is a more robust mode. It is a gamma calculation beam model in which each daily portal image is compared to a planned image for that particular field. The predicted is based on the RT plan, calculated based upon the Adaptivo beam model, which must first be commissioned by your facility. The other mode is kind of what we use as a backup mode. It is less robust. It's the relative mode. It is a gamma calculation in which each daily portal image is compared to a reference port. The default reference image is from the first day of treatment, but it can always be changed by the user. Now, we always start out with the predicted mode, but in certain situations, we have to switch to relative mode, so we have that available to us. One of the situations is if you have variant enhanced dynamic wedges. The predicted mode does not work properly, so we have to use relative mode because there are some limitations. Another one is if you have a lot of MLC blocking on central axis. The predicted mode sometimes will have a shift in the normalization of the image. So if you switch to relative mode, because of that low dose gradient on central axis, you'll be comparing simple port to port, and you'll have a much higher success with the gammas. So because of the predicted mode is a more robust gamma calculation model, it is our default mode used in all of our clinics. Next, I'm going to present our first case. This is changes in lung anatomy. The body region we are treating is the right lung and mediastinum. We are using a VMAT rapid arc procedure. And this particular patient had recent SBRT to the right lung, so we want to make sure we minimize dose. And of course, we're using the predicted mode. So the clinical information in supporting the rationale for replanning based on results from Adaptivo in vivo dosimetry are as follows. The first one is the need to minimize dose wherever possible due to the previous SBRT within the current treatment region and overlapping volumes. This patient had significant fluid in the right lung during CT simulation. And because of that, it affected the planning because this is the same CT study that was used for that treatment planning. Next slide is our particular physician was concerned about the total dose to the lung, so he decided to go with BID fractionation due to that previous SBRT treatment and due to relatively large volume now being treated to a fairly high dose. The previous SBRT treatment was at 7 gray per fraction in 5 fractions to a total dose of 35 gray. The current prescription is for an additional 65.5 gray. So as you can see, the potential to exceed 100 gray in total dose is very real in this particular case. The area previously treated was considered an at-risk structure because we needed to make sure that we minimize the total dose to prevent necrosis in the patient's lung. Any changes in internal anatomy could potentially result in an overlap between the current and previously treated PTVs with unacceptable hotspots, increasing risk for tissue necrosis. This is a simple screen capture of the final prescription. The original prescription was BID to 1.25 gray per fraction for 38 fractions, so a total of 47.5 gray. This prescription amendment reflects the discontinuation of the initial course early and to modify the existing boost. The original prescription had the initial going to 50 gray with a 12.5 gray boost using the original CT study. You can see now it says SIM2. So there's a new CT study that is being used to do the boost planning. Now, for those of you that are familiar with the Adaptivo software, for each treatment plan for each patient, you get this bar that has these little squares. We refer to these commonly as the chiclets. So as you can see, for the first 6 weeks of treatment, everything looked fine. Green means above tolerance. So we were passing above our set threshold. And then all of a sudden here, we start to see yellow. And then on the end, which are true failures. The yellow is considered borderline tolerance, and the red is considered a true gamma failure. If you click on any one of these chiclets, you get the expanded view, which is the larger view that you're looking at now, which should match. So up on the top bar, this first yellow chiclet would represent this gamma failure here at 79.5. It was slightly below our threshold of 80.0. So you can see as time progressed, the gamma started getting worse with more failures and more borderline tolerance results. Now also, you see there is a vertical column that is gray. That is different from the columns that are not gray. For example, fraction 31 here is a daily result, and if I go to the end, it says average result. So every week, the Gamma software will take a composite image of your 5 daily images and then run a new Gamma on it using that average image to give you the average Gamma result. It also shows images of what your pixels look like in the Gamma analysis. So if the pixels show up as red, that means they're the hot areas, and the blue is the cold areas. In this particular case, for this particular beam on fraction 35, this is arc 4, you see all we see is red, meaning that the patient is getting more dose than predicted. And that is possibly due to the tumor regression and weight loss for this patient. Definitely a change in anatomy that needs to be taken into consideration. It also shows very nice profiles. The one on the left is in the x-axis, the one on the right is in the y-axis. For this particular beam, the red line is showing the predicted dose, and the green dashed line is showing the portal dose. And you can clearly see that the entire field is receiving more dose for that daily fractional treatment than you did in the predicted. Another view of this to show our dose tolerances as well, our Gamma tolerances, is this view here. For that same particular arc, on the left, you see the percent Gamma. So this is at 5%. And we're using a DTA, distance to agreement, of 3 millimeters. So the result is 57.71, which is below our failure threshold, and it shows up as red. The green, of course, is above threshold. The yellow is borderline threshold. And then the red would be failures. And it's pretty obvious. For example, if I use this very first one here, 17.73, that's with the dose constraint of 1% and a DTA of 1 millimeter. Almost all pixels will fail that. Oppositely, if I go to the far right-hand corner, a dose threshold of 10% and 10 millimeters, almost all of the gammas will pass. All of the pixels will pass that gamma. This is a very, very helpful view. It shows a trend analysis over time. So as you can see, for the 4 arcs, everything seemed to do fine for the first 6 weeks. And then all of a sudden, they started to go downhill. And they started to trigger notification to the physicist. And I'll talk a little bit more about the notification of the physicist on a future slide. So this particular one here was the first notification I received on June 29th. So I analyzed the gamma failure, and I had to put in a conclusion. We call it a physics memo that goes into the gamma report. So I'll just read this to you. It says arcs 1 through 3 were borderline tolerant, and arc 4 was below level on the daily in vivo dosimetry on June 29th due to a change in anatomy. There was fluid in the lungs during CT stim, but none of the images from today. There's also a possible regression of the tumor. The radiation oncologist was alerted by email on June 29th to evaluate for clinical significance. So this was on June 29th. Then on June 30th, of course, I had another gamma failure, so I responded accordingly. This was the memo from my report. That arc 2 was borderline tolerance and arc 4 was below level on the daily in vivo dosimetry on June 30th due to patient weight loss and a change in patient internal anatomy. There's also regression of the tumor. The radiation oncologist has decided to discontinue delivery of the current plan at fraction number 38 and replan with an adaptive boost. These are some images that were taken from Varian offline review, and most of you are probably familiar with that. First, I'd like to talk about weight loss. You can see this particular image on the left, the larger image, is an overlay of the planning image as well as the daily cone beam CT. The images on the right, the upper one is the planning CT, and the one on the bottom is the cone beam CT. So the one on the left is an overlay of those 2 images. And you can clearly see in this region, there's patient weight loss, as well as in the opposite side. It's even more clear on the image on the lower right. You have significant weight loss here and significant weight loss here. You also have a lot of fluid that was in that particular lung. There was even a little bit of fluid in the opposite lung. As you can see on the lower right, that fluid has resolved and is almost non-existent. Finally, tumor regression. That is what we're all mainly concerned about, not just dose, but we want to make sure we're targeting the tumor. And you can see in this case, there was a significant regression of the tumor on this region right here. And of course, this is just a single slice through the patient's anatomy. So if you were to scroll through each of the slices, you can see varying degrees of these effects of weight loss and tumor regression, as well as the fluid in the lungs. I know this is a busy slide. This just shows the overlay. It's a summation plan that shows the initial SBRT volume as well as the current treatment volume. The red line, if you can follow that, that is the actual revised PTV for the boost. Now, the maximum dose is going to almost 104 gray. So again, it's very important that we follow this closely to make sure that we don't cause problems in the patient due to tissue necrosis. So for case number 1, in summary, Adaptivo alerted the staff that there were significant changes to the patient's anatomy, including weight loss, tumor regression, and a significant decrease in the fluid within the right lung. Based on the information provided by Adaptivo, the physician discontinued the initial plan early and re-CT'd and replanned the patient's boost. So if we had gone with the original boost without replanning, I have no idea what the gamma results would be, but I'm sure they would not be this good. With the new revised boost, all 12 fractions easily were above threshold and passed gamma. Next, the physician was able to increase the boost daily dose from 2.5 gray up to 3 gray because of the smaller treatment volume. The end result is a significant reduction in the treatment volume, an increase in the tumor dose, as well as a reduction in dose to normal tissue. So next, we're going to talk about case 2. Case 2 was considerably different than case 1 because for case one, the doctor suspected that something may be going on. So he wanted to have us follow these with Adaptivo. And so he had requested that in his prescription. For this particular case, the doctor figured he did not need Adaptivo, so he did not request it. But in our facility, our policy is to run gammas on every patient in the background automatically. It doesn't take any effort by the physicist. And we're still notified and we still respond accordingly. But if the doctor did not request it in his prescription, the reports do not go into the patient's record. So that's one of the big differences here. So this particular case, changes in neck anatomy. The anatomical region is the right neck, and we are using the VMAT rapid arc technique. There's no previous treatment to be concerned about. That helped in this case. And we're using the predicted mode of gamma calculation. So the clinical information supporting the rationale for replanning this particular patient based on results from Adaptivo in vivo dosimetry are as follows. The neck region has many anatomical structures, such as the parotid glands, major vessels, the spinal cord, etc., in which it is important to minimize dose to these organs at risk. It is also fairly common for the neck anatomy to change during treatment in patients being treated for head and neck cancers, such as due to patient weight loss or gain, or from tumor regression. Even small changes in neck anatomy can significantly change the dose received by the spinal cord and other tissues, as I'm sure most of you have experienced in your careers. Tumor shrinkage and weight loss can also result in significant dose unintentionally being delivered at a greater depth, and that is always a big concern with weight loss. So here is a screen capture of the final prescription, and it reflects the amendment to discontinue the initial course early and to add a modified initial course as boost 1. So originally we were going to 28 fractions. In this case, he stopped it at 23 fractions, and then we did the new boost with the new CT sim for the remaining 5 fractions, and then had an entirely new boost 2 based on that new CT. So the original prescription had the initial going to 50.4 gray in 28 fractions with a single 19.8 gray boost using the original CT study, not a re-sim, but the original. And you can see in the prescription here, sim 2 and sim 2. So he did re-stimulate this patient for both boosts. This is similar to what you've seen before, except you do not see any red chiclets or any red boxes. There were no gamma failures here. These are all borderline tolerance results. Now, the reason I did this screen is because this particular patient had been archived out of the Adaptivo server. So we had to restore the patient. And when you restore the patient, everything is calculated a second time, so you see the red flags. If I were to click on these red flags and respond, I would get duplicate records for this particular patient. So that's the reason I chose not to do that. So once you click on it and respond to it, then they turn gray. Now, every time you see a flag that shows up, both here on the top and on the bottom, an email is automatically sent to the user, to the physicist. So that way they are aware of the below tolerance results, or in this case, borderline tolerance. And that way we are alerted and we can respond accordingly. Now, for the daily fractions, we do not get notified if there is a intermediate or borderline result. However, when we do the average on a weekly basis, even a borderline tolerance result is important enough to go ahead and have the physicist notified by email, so that way they can respond in a timely manner. These are images similar to the previous patient, but in this case, we see both blue pixels and red pixels. The red pixels for, this is fraction 20, arc 1, is the blue pixels are in the area of the shoulder, and sometimes if the shoulder position is not the same as it was during the original CT sim and planning, you can have some additional attenuation. So those are cold spots in the area, probably due to the shoulder. The red pixels are hot spots, most likely due to tumor regression and or weight loss. Again, these are the profiles. The one on the left is the X profile and the right profile. By the way, these are through central axis. So you can see on the left, The green, which is the actual dose the patient is receiving, is higher than the predicted. But if you look on the right, there's a differential here. In this particular region right here, I suspect that is due to the shoulder attenuating some of the dose. The shoulders were probably higher than they were during original planning. And in this region over here, the dose is hotter than predicted, and that is probably due to the tumor regression. In this case, we had borderline tolerance results using criteria of 5% dose and 3 millimeters DTA. And you can see the trend is very subtle, but there is a general decrease almost the entire treatment. There are some daily variations, which there always will be based on setup, maybe the patient coughed. It's hard to say, but the general trend is going down, it's deteriorating. And if you even look at these numbers, every single weekly average is going down until we start to see more and more borderline tolerance results. So in my opinion, on this particular patient, this was enough information to prompt me to talk to our radiation oncologist and first see if he wanted gammas, and he did. He changed his prescription and requested gammas on the prescription. So now the reports would go into the patient's medical record. There are several other images or screens that you will see in your report. These are coming from a weekly report, and it actually shows you what your threshold is for the passing. So this is 80%, and these thresholds have been decided long ago up at our corporate level. So in the future, we were told that these may be something that you can change and have them patient-specific or maybe anatomical site-specific. But for now, we are using 80%, 5% dose, and 3 millimeters DTA. So when I received the first notification, that was the weekly notification, because we do get notified weekly if there is a borderline tolerance result. So this is my response in the report. So 3 of the 4 ARCs were borderline tolerance on the weekly average in vivo dosimetry on July 13. This is possibly due to changes in patient anatomy with possible tumor regression. Additionally, the variable position of the shoulders in the beam may be contributing to the borderline tolerance results. Note that the doctor did not request gammas in the prescription, but the doctor has been made aware of this via email on July 13th. So I just wanted to document that he was made aware of that. Now you can see in this image, if there is some tumor shrinkage, patient shrinkage, tumor regression, it is very subtle. The changes are very subtle because a lot of it's soft tissue. I can see right here there may be some patient weight loss or tumor regression taking place, but it was still enough to trigger the gammas, especially on the trend analysis, to see that there was deterioration in the gamma pass rate. So the image to the right is an overlay of the planning CT image and the daily cone beam CT from July 13. Even though changes in patient anatomy were subtle, it was enough to show a decreasing trend over time in the gamma pass rate. So in summary, Adaptivo, again, alerted the staff that there were changes to a patient's anatomy, including possible weight loss and tumor regression. Even though there were no outright gamma failures, borderline tolerance results and the decreasing trend in the gamma pass rate were key. Note that based on the original prescription, the boost had been planned on the original CT study. Now, based on the information provided in the reports within Adaptivo, the physician discontinued delivery of the initial plan early and re-CT'd and replanned for 2 separate boost volumes. The end result is a significant reduction in treatment volume and a reduction in the overall dose to normal tissue due to what I consider true adaptive planning. Now, I'd like to close by just saying that this particular physician, after seeing these results, he is more likely to request Adaptivo in his prescriptions, so that way the reports will go into the patient's medical record, because he sees the benefit of this and he knows that it definitely makes a difference in the outcome of the patient's treatment. Thank you very much, and I'll turn it back over to Mary.
Thanks for the really nice and informative presentation, Brian. So now, if anyone has questions, if you could please put those into the chat dialog box, and we'll give you a few minutes to do that to see if anyone has questions. I see one popping in. If you want to go ahead and take that one, Brian.
Sure, I will take that. Apparently, and I wasn't the person who chose the 80% gamma tolerance. By the way, I'll read the question. It says, is there any particular reason to choose 80% gamma tolerance? I was told that this was based on a European study that found that 80% threshold on the initial pass was a good pass criteria to use. And that is why our company has chosen to go with the 80%. If you make it too tight, you get a lot of gamma failures for just daily variations in setup or daily variations due to slight patient motion, which is common on a daily basis. And if you have your constraints too loose, you'll never get a gamma failing. So it's a useless tool at that point. So 80% was chosen by our corporate office through our physics staff there. I see another question. It says, daily dose is calculated with cone beam CT directly. Any deformable image registration correct the Hounsfield unit? There, and this is probably a question Mary can answer. I believe that is being considered in possibly a future update. There is an additional mode that is supposed to be in addition to our relative mode and our predicted mode. It's like a true adaptive mode, but I don't know what the status is. Mary might be able to answer that question.
Sure. Yes, there is an adaptive mode within Adaptivo, and there are customers of ours that are using the adaptive mode. It does, in fact, calculate the daily cone beam CT with deformable image registration.
Thank you, Mary. I see another question. It says, in your gamma analysis, what is the meaning of hot and cold? Hot is anytime you have a pixel that has a higher failure than the predicted, or higher dose, I'm sorry, the higher dose than the predicted, and that is based on each pixel. So if there's a cold pixel, it means that the actual dose that has been measured by the portal imager with the exit dose from the patient during the treatment of that particular beam, that particular pixel would have received less dose than what would have been predicted by the Adaptivo software. So that is how I'm using the difference between hot and cold. And the other questions I think were already answered.
Yeah, I think that. Go ahead, Brian.
No, I was just reading one. It says, which are your criteria for choosing to use Adaptivo? That, of course, we're a large organization. We were 21st Century Oncology. Now we're Genesis Care. We have a lot of offices. So each individual office, each individual physicist, or even physics group within our company, we do have input on how to go with different software. But it is my understanding that a lot of the preliminary research and development of the software had been done within 21st Century Oncology in the past before they joined up with standard imaging. So I believe that might have had a lot to do with why we are using Adaptivo.
Okay, and we'll just give folks a minute or so to type in any other questions. And if there aren't any other questions, then we'll close the session. But I'll give everyone just a minute. Type faster if you're typing a question. Okay. Well, I think that's all our questions for today. And thank you very much for attending. And we hope you'll keep joining us in our future webinars. Have a good day.
Yes, thank you, everyone.